circuitry here, what's happening. So I like to make things as simple as possible. This is a diagram that I've always used that helps me just kind of understand this without seeing it in this anatomical relationship. So we're going to start with this diagram that's more of just this linear diagram of the circuitry of the basal ganglia to help you understand the basics of it. And this is really, to be honest with you, really is all you need to know. I will show you some more slides as we get into how it's more anatomically arranged, and also when we talk about things like Parkinson's versus Huntington's and what's happening within the circuitry that allows too little movement or too much movement. Okay, so we have a direct loop or a go loop, and we have an indirect or a no-go pathway through the basal ganglia. These are both working. They're both there at the same time. They're both working at the same time, counterbalancing each other. The direct pathway increases motor output. The indirect pathway decreases motor output. And when you have a normal amount of dopamine and a normal amount of acetylcholine influencing the direct and indirect pathways, you have a certain basal amount of motor output activity that's available to you. Okay? If you want to increase motor output, you squirt a little more dopamine into the system. If you want to decrease motor output, you maybe don't squirt as much dopamine. There's always some going into the circuitry, but you lessen it or you increase it. Okay? It's primarily how you ramp up motor output or decrease motor output. Okay? So let's just go through each of these pathways individually, though, and show you the connections. Keep it simple here. Anything with this solid arrow, so solid, those are positive connections. Dashed is negative, okay, or inhibitory, so excitatory, inhibitory connections. In this case, between these, it's always going to be, if it's an excitatory connection, it's going to be glutamate. If it's an inhibitory connection, it's going to be GABA, okay, between these different nuclei. So let's follow the path through the direct pathway first and see why it increases output or motor output back to the cortex. Okay? So remember, the signal starts in the cortex. It goes to the striatum, which is the input nuclei. The cortex excites the striatum. The striatum is inhibitory to the processing nuclei, globus pallidus, internus, substantia nigra, reticularis. And the processing nuclei are inhibitory to the thalamus. So if you're increasing the striatum's ability to inhibit the inhibitory influence of the processing nuclei, now these ones can no longer, the output nuclei, sorry, these are output because they go to the thalamus. If you inhibit the inhibitory influence of those, you actually increase the output or activity, and you have increased excitation out of the thalamus. The thalamus is always excitatory back to the cortex. So you basically release the thalamus to be more excitatory. If you want to think of it in purely mathematical terms, two negatives always cancel each other out. Two negatives make a positive, right? And that works in neural pathways too. If you inhibit an inhibitory structure, it becomes more excitatory. If you inhibit the inhibitory influence of a structure, it then is less inhibitory on that motor thalamus, so the motor thalamus can work better or have more excitatory influence over the cortex. So so in this particular pathway, the direct pathway, you have a positive, a negative, and a positive. The two negatives cancel each other out. So we have positive, positive. It's a positively influenced loop, the way that all works together. It gets really messy when and you can do it in your head, is follow, well, this excites the striatum and it makes it better at inhibiting the inhibitory influence of the output nuclei over the thalamus, so that thalamus is less inhibited, so it's more excitatory back to the cortex. But that gets messy in my head. So if I just think, all right, it's got two negatives, make a positive, boom, everything else is positive in this pathway, it's excitatory back to the cortex. The indirect pathway is inhibitory. And if you want to think about it this way, purely like a mathematical problem, you've got an excitatory connection, but now it's indirect because it actually has a couple extra stops. It has, instead of going directly to the output nuclei, it goes to two other nuclei. It goes to the globus pallidus external segment or externus, then to the subthalamic nucleus, then back to the globus pallidus internus and SNR, which are the output nuclei, then back to the thalamus. So it's this little more indirect loop. But here we have a positive, and a positive, but we have another negative. So these guys cancel each other out, but we have a negative still in that loop. And so the negative always wins in math, right? So it's overall, it's a negative influence over that entire pathway because we have that extra negative in that loop. So, but you can talk it through and say, this one inhibits this, which inhibits that, which inhibits the facilitatory influence of one over the other, and it gets kind of messy in your head, but, and really all you have to know is that the indirect pathway, the overall additive effect of all those connections is a decrease in excitatory influence back to the cortex. And that the direct pathway is excitatory. It increases excitation of the motor thalamus back to the cortex, increases excitation, where the indirect decreases excitation of the thalamus back to the cortex. It's less excitatory, so it's basically inhibitory. It's important to know that the indirect loop involves these different nuclei and the direct is that, but knowing every single connection here is not all that relevant. You don't have to know every excitatory and inhibitory connection. You need to know the added effect of all those together, what the ultimate, how that influences the output of the thalamus back to the cortex. The direct pathway makes the thalamus more excitatory back to the cortex. The indirect pathway makes the thalamus less excitatory back to the cortex. Okay? So now let's throw dopamine in the mix. Both of these pathways, they're working at the same time, and both are influenced by dopamine. Okay? Here's this. I'm just going to draw the subthalamic substantia nigra out here. This is substantia nigra. Substantia nigra. The pars compacta has cell bodies, dopaminergic neurons, cell bodies that have axons that project to the striatum that influence both the direct and indirect pathway. Okay? There are D1 receptors in the striatum, and there are also D2 receptors in the striatum. You have both D1 and D2 receptors in the striatum. When dopamine is being secreted into the striatum, when it falls on D1 receptors, it increases the strength of the direct pathway. It increases the activity of the direct pathway. Makes the direct pathway have a stronger influence, and it inhibits the indirect pathway and makes the indirect pathway have less influence. So the net effect is now the direct pathway is a stronger influence than the indirect pathway, so you get a net increased motor output out of the thalamus back to the cortex. So dopamine inhibits the indirect pathway and excites or facilitates the direct pathway. Since the direct pathway is more excitatory, it's going to do more, it's going to play a bigger role in motor output. So there are times, though, you want less motor output, where you just want to sit and be quiet and not move or fidget and those kind of things. So there's times when your substantia nigra will say, let's decrease the amount of dopamine in the system, and let's let the direct pathway come down a notch. Let's not inhibit the indirect pathway so much. We're wanting to be quiet and not move. But then when we want to move or do something really explosive, we've got to squirt more dopamine in there, really ramp up that direct pathway and turn down that indirect pathway. So that's what dopamine does. Sort of make sense? So here's a more anatomically correct schematic of that. This is essentially the loop we're talking about right here. Okay, this is the direct loop. These pictures are from on the Isidore. There's a resource. There's a basal ganglia um, paper that talks about the basal ganglia. It's probably the best description of the very basic functional, the function of the basal ganglia that I've read. And these pictures are pretty good. Okay, and so that's why I pulled them out of here, and you can see those again. So this is the direct pathway. And then here's the indirect. They're all together. They're working at the same time. It's just that depending on how much dopamine is in the system, one is more influential than the other. Okay. So here's your cortex. This is the striatum, which is your caudate and putamen together. So that's what they're showing, caudate, putamen. So excitatory connection. The direct loop goes right to the internal segment of the globus pallidus. And directly from the internal segment, it goes through a little thing, part of the brain called the ansa lenticularis. Don't worry about that. That goes up to the motor thalamus, the VA and the VL, the ventral anterior and ventral lateral parts of the thalamus, and then back to the cortex. Okay? And here we have our negative and our negative right here that are canceling each other out, which makes this a net positive influence back to the cortex. Then the indirect loop here starts in the cortex, goes to the striatum, goes to the external part of the globus pallidus first, then to the subthalamic nucleus, then back to the internal segment, then to the motor thalamus, then back to the cortex. But we've got our three negatives in there, so the net effect is an inhibition back to the cortex, or inhibition of the motor thalamus that goes back to the cortex. Okay, so that's the indirect pathway. And then that's how you eventually then influence. This is the lateral cortical spinal tract down to the lower motor neurons. Okay. Now what we're doing here is showing you, this has both the direct and indirect loops overlaid, or on top of here. So here is the, here's the direct. So here's the direct right here, direct through, okay? Here's the indirect right here, going around that way and through with the extra connections. So they're all there at the same time. We have a direct and indirect pathway. But here's the substantia nigra, the pars compacta. Here's our dopaminergic neuron in here with an axon projecting up to the striatum. Dopamine excites the direct loop when it falls on the D1 receptors in the striatum, and it inhibits the indirect loop when it falls on the D2 receptors. So whenever dopamine's in there, it's falling on both D1 and D2 receptors. The more dopamine, the more activity you have going on. If not enough dopamine, the less activity. And there's a side effect. So people that take Parkinson's medications, some of them have these called dyskinesias where they're moving all the time that are induced by, they're drug-induced dyskinesias because they're dumping too much dopamine agonists and dopamine into that system. And normally our body is very good at titrating how much dopamine goes in just for the task. But when they take their medicine, sometimes there's too much in there, so they have excess movement, even at rest. They're sitting there moving around, having this response because there's too much dopamine. And sometimes the receptors also get, as you lose dopamine in your system, the receptors that are left, well, they're realizing we're not getting enough, so they become more sensitive to the dopamine in the system. Then when you start taking medication, your overly sensitive receptors can pick up that extra dopamine and make you have some dyskinesias and so forth. And that's actually a side effect of some psychotropic medications that are dopamine agonists. So some people that take, for psychotropic reasons might have a little excess movement or something like that. They're called tardive dyskinesias. Those are drug-induced dyskinesias. Excess movement is called tardive dyskinesias. So there's everything all in one shot there of everything combined. Now we're going to talk about what happens when there's problems with this circuitry. And we can broadly divide into two categories: hypokinetic disorders, things that cause too little movement because of damage to the basal ganglia, and hyperkinetic disorders that cause too much movement, okay, because of damage to the basal ganglia. So we have our classic idiopathic Parkinson's disease. Idiopathic, we don't know why it happens, okay? It's degeneration of the substantia nigra. They don't know if it's a combination of environmental plus genetic or what. Gut bacteria now, there are all these kinds of different theories why people have this. That's the most common, okay, is idiopathic Parkinson's. There's other types of Parkinsonisms. So Parkinsonism are diseases that have a lot of the features of Parkinson's disease. They have the bradykinesia, the akinesia, the slowness of movement, and so forth. But they're not idiopathic Parkinson's disease. They're diseases that affect the basal ganglia that cause too little movement, but they're not idiopathic Parkinson's. So toxic. There's certain, like manganese poisoning kills basal ganglia cells and substantia nigra cells, and that causes infectious. Certain infections, bacterial and viral infections can damage basal ganglia and dopaminergic neurons. Traumatic. People that have lots of concussions or trauma, like boxers, what do they call it? Parkinsonism pugilistica. Pugilism is boxing or hitting or punching. And so your brain and your midbrain come together, right? And every time your head gets pounded or knocked, there's a little twisting and rotary motion between your midbrain and your cerebral cortex, and those substantia nigra axons that are coming from your substantia nigra to project up to the basal ganglia, they're right in that area. So you can actually damage those little axons so you get Muhammad Ali is a perfect example of, of having Parkinson's disease, probably related to his boxing, but he could have idiopathic, but some of that it can enhance or make it worse, or symptoms get worse sooner because he's damaged that connection between the midbrain and the cerebrum, okay? There's also a group of disorders called Parkinson's plus syndromes. Parkinson's plus syndromes, these are symptoms that give you Parkinson's-like symptoms plus extra fun stuff, It generally involves degeneration of both the basal ganglia as well as some other nuclei within the cerebrum and the brainstem. So that's why I call it Parkinson's plus. You get the Parkinson's symptoms, plus you get degeneration of other areas of your brainstem and cerebrum as well, okay? So things like progressive supranuclear palsy. You get Parkinson's disease, but you also get degeneration of the oculomotor areas in your brainstem that make it hard to direct your gaze. Starts out vertical gaze is a problem, like they sit there and they can't look up or down with their eyes. And they also often have impairment or degeneration of some of the autonomic centers in the brainstem, so they have blood pressure problems, they have cardiac regulation problems, and so forth. That's also part of the symptoms of multi-systems atrophy. MSA is called multi-systems atrophy. It's basal ganglia, it's autonomic function. It doesn't involve oculomotor function like PSP. That's a very specific Lewy bodies disease is a form of Parkinsonism, but also has a lot of dementia and it's got like Alzheimer's-like qualities to it. And actually, a lot of people with Alzheimer's eventually get some Parkinson-like symptoms. Those deposits, the protein deposits that start out in the more frontal and temporal lobes, can also influence eventually some of the basal ganglia circuitry. So people get, even with severe dementia or Alzheimer's, can get some Parkinson-like symptoms eventually. Then we have our hyperkinetic disorders, too much movement. Huntington's disease is one that causes too much movement. You saw Huntington's chorea, the choreic movements. Those are the excess or hyperkinetic movements. There's another really awful disease to have is a dystonia. I don't know if you've seen like videos. These people get these really cramping, static posturings, and they just can affect their arm, their face, and they're super painful. And you see people that are trying to walk, and it's this cramping, spasming, and it's called a dystonic movement, where it's just this forceful, sustained contraction of muscles. And it's kind of like changes a little bit all the time, but it's just really painful to watch. Cerebral palsy, certain types of cerebral palsies can have too much movement. The choreic athetosis form of cerebral palsy that causes damage to certain parts of the basal ganglia circuitry that cause too much movement. And then hemiballismus, remember that's a stroke in the subthalamic nucleus. The subthalamic nucleus is part of that indirect loop, which helps to decrease movement. When you damage a subthalamic nucleus, now the indirect loop isn't doing its job and you have too much movement. You're wanting that balance between direct and indirect loops. You lose that balance when you have damage to the indirect pathway. So a lot of these have to do, some of them anyway, have to do with damage to the indirect pathway. And so the indirect pathway normally downregulates movement, but now they've got too much movement because the indirect pathway isn't active enough. So, yeah.
Where does the CTE fall in there?
CTE. I think it can. I think CTE can influence. I mean, CTE causes some deposits in the brain, but also can shear axons. So, it can damage basal ganglia circuitry, I'm assuming, and also especially at that midbrain junction, like I was telling you, between the cerebrum and the midbrain. So we're going to talk about idiopathic Parkinson's disease briefly here. There's 4 cardinal signs. There's rigidity. So they're rigid, they're stiff, okay? And that actually the rigidity has to do with the basal ganglia also influences not just the cortex, but it influences a couple key nuclei in the brainstem. And it influences what's called the pedunculopontine nuclei and the locomotor region of the brainstem. There's a couple nuclei in the brainstem, so doesn't just go back to the cortex, but the basal ganglia influences a couple brainstem nuclei. And when you have problems with your basal ganglia, what it leads to is the brainstem nuclei no longer have their normal input, and that causes some of your postural and gross motor muscles, especially the medial activating system, the reticulo and vestibulospinal tracts, to be a little overactive, and you get stiff. You get kind of stiff, and you get co-contraction of muscles, and they get really rigid. Okay. The akinesia and the bradykinesia are mainly because of the lack of motor thalamus input back up to the motor system, so they can't initiate movement. That's the akinesia, the lack of initiation, that delay. And then once they do move, it's slow. That's the bradykinesia. They may have a resting tremor. Not always. There's actually 2 different major types. There's a tremor predominant Parkinson's disease, where they have lots of tremor, but they don't have a lot of bradykinesia or akinesia, and they don't have a lot of postural instability. That's called tremor dominant Parkinson's. That's the best one. If you're going to get Parkinson's, you want the tremor dominant. It responds best to the medicine. It responds best to deep brain stimulation, and it progresses slower. Then there's another one that's a postural and gait instability variant, where they have less tremor, but they have lots of problems with rigidity, posture, stability, and gait. That's the worst one to have, because it responds less to the meds, less to the deep brain stimulation, plus the consequences are higher. You don't walk as well, so you're less active, plus you fall more. And then you have the sequelae of falls. So that's the postural instability. But you usually have all 4 of these. It's just that the tremor predominant have more of this, and the postural and gait predominant have more of that. But they all have a little bit of this. The deep brain stimulation, like I say, it's good at helping tremor. It's good with some of the bradykinesia and akinesia, but it doesn't do very good for postural instability and gait. It doesn't ameliorate those problems very well. Physical therapy does better than the meds and the deep brain stimulation does for improving gait and balance. I don't know. I mean, I haven't seen him without meds earlier on to know if he was having more tremor or not. I would say so, because he doesn't seem to have that postural gait stiffness. He's got the masked facies, but I would say he's probably more tremored upon. And the fact that he's still alive after he's had it so long, he had that young onset, I'd say he's probably had more of a tremor, predominant one. And you can see if you see Michael J. Fox, from the side effects of the meds, he's got a lot of tardive dyskinesias, and so you always see him kind of, doing this with his pockets, and he's trying to semi-purposely mask those extra movements he's having from the meds, causing some of those excess movements. So the pathophysiology of idiopathic Parkinson's disease is you get loss of dopaminergic neurons in the substantia nigra, the compacta, the pars compacta part. Those start to die off. This leads to a decreased activity in the direct loop and an increased activity in the indirect loop, because now you don't have enough dopamine going in to excite the direct loop and inhibit the indirect loop. So now the direct loop's not as active, but the indirect loop is more active because it's not being inhibited. And so the net effect is less motor output or influence going back to the cortex. So that the net is a decrease in output from the motor thalamus back to the cortex. But then I mentioned also there's a net increase in activity of the reticulo and vestibulospinal tracts. That's because of the role or the connection of the basal ganglia to what's called the pedunculopontine nucleus. So just understand the basal ganglia not only influences the cortex, but it influences a few brainstem pathways too. Okay? So the influence over the cortex is for that goal-directed voluntary motor behavior. The influence over the brainstem, it does have some influence over some of that background postural set and tone that we have via the reticulo and vestibulospinal tracts. There is a scale that's used to describe kind of the disease process, a 1 to 5 scale called the modified Hoehn-Yahr scale. Most Parkinson's starts out unilaterally, one side only. One side has a tremor, or one side, you notice their arm isn't swinging on one side. So that's level 1. Eventually, you get bilateral. As soon as you start to notice symptoms on both sides, or they have a little bit of axial involvement, their trunk starts getting stiff, that's level 2. 2.5, bilateral disease with recovery on a pull test. So they have bilateral disease, and you do a pull test. Either you usually pull them backwards, but they can recover. So they've got bilateral disease. It's a little more severe than a 1.5. I'm sorry, 1.5. I'm sorry. Than a 2. It's a little more. They still can have some impairment of balance. Now 2.5, they get some impairment of balance, but they can still recover on the pull test. You notice that they just don't quite have the same amount of balance, but when you pull them, they're still able to take a step back and catch themselves. 3 is mild to moderate bilateral disease, some postural instability. At this point, they're probably struggling with that pull test. They're not having consistent ability to recover from a pull test, but they're still physically independent. A level 4 is severe disability, still able to walk or stand unassisted, but they're probably requiring some care. They're not taking care of themselves at this point, but they're still able, with given enough time and the right conditions, can stand up and walk unassisted. May need a walker, may need a cane or something like that. The level 5 is wheelchair bound or bedridden. So it's a pretty gross scale. It's actually not the greatest scale. It doesn't have a lot of validity to it, but it's very commonly used. So just you should know, if you're walking into a patient's room and it says they're a Hoehn-Yahr 3 or 4, just know that 4 and 5 is bad. If they're a 2, 2.5, that's not so bad. They're probably more mildly involved. So 3 is kind of, moderate. This is just showing you a cross-section through here of this is the midbrain. This is a normal midbrain. There's the substantia nigra. This is the red nucleus right here on each side. But you can see the darkness in here. That's normal. You want to see that good, dark, melanin-stained dopaminergic neurons. Melanin's a precursor to making the dopamine, the neurotransmitter, so it's a little bit of it's got substantia nigra. Nigra is black, dark, so dark stained. Here's somebody with Parkinson's. See how much lighter it is? You hardly see any darkness because you've lost a lot of your dopaminergic neurons. Most people do not experience symptoms until they've lost 80% of those neurons. You have plenty in reserve. You have some to lose, but you get to a threshold. The threshold is when you lose about 80%, and now you start to have symptoms. And there's really showing that for us as physical therapists that we need to be very proactive in fighting for therapy for patients upon very initial symptoms and initial diagnosis. The sooner you get them into therapy and the more aggressive you do a training program of fairly high to moderate level aerobic activity combined with very dynamic movements that involve big movements, rapid movements, loss of postural, reactive balance control, slips, trips, then you can actually maintain people's function for years. But it's got to be 3 to 5 days a week. It's got to be pretty intense. It's got to be challenging. But the earlier you get them into it, the better the response over the long term. And that just came out like last month in either the APT, in the PT journal or the Neuro journal. They did a 2-year study where they tracked for 2 years people participating in an aggressive evidence-based Parkinson's exercise program, and they were able to maintain function, the same level of function for 2 years without any loss of function for 2 years in these individuals through exercise. So it's very powerful as exercise. It maintains the health of the remaining neurons, and it makes the ones, even as you die, the receptors are more healthy, the connections still tend to work better, and so anyway. So this is just another schematic that's from your book that shows, here's the basal ganglia. Normal is kind of showing this balance between voluntary muscles and postural girdles. So all I want you to appreciate is kind of the size of these arrows, and there's a balance between the two. So there's the right amount of output going to voluntary muscles and the right amount of a facilitation of postural and girdle muscles for normal movement. With Parkinson's disease, you'll notice that you now have too little, the arrow is smaller. You have too little movement of voluntary muscles, but because of the role influence over this pedunculopontine nucleus in the brainstem, you have too much motor output to postural and girdle muscles. This is where the rigidity comes from. And this is where the akinesia and bradykinesia comes from. That's all I want you to know from that diagram. Not every connection in there, just know that the general thing, what happens with Parkinson's. I mentioned already this Parkinsonism. You know, this term Parkinsonism is associated with lots of different disorders. I mentioned toxic, so manganese poisoning, even carbon monoxide poisoning. Somebody who survives after being poisoned by carbon monoxide, some will have Parkinson's disease afterwards, because carbon monoxide goes and seeks and destroys dopaminergic neurons initially. So if you live past the carbon monoxide poisoning, there's a good chance you could come away. If it's a severe exposure, we could come away with Parkinson's disease. Infectious, encephalitis lethargica, just an encephalitis that impacts the dopaminergic neurons. Traumatic, the encephalitis pugilistica that I was mentioning, the encephalitis pugilistica, which I think could also be, CTE could probably be very similar to this encephalitis. You're getting pounded in the head over and over again. That repetitive trauma causes disruption of axons between nuclei. Then the multi-systems atrophy I mentioned, these are all Parkinsonisms. These will often have some combination of more cerebellar and autonomic dysfunction in addition to the striatonigular degeneration. This is the Parkinson's part. There's like a list of probably 25 of these that have some form of Parkinson's, this multi-systems atrophy of degenerative diseases. There's a lot of them, believe it or not. Okay. You know your patient, so this is your classic thing. A patient comes in with Parkinson's disease. The doctor says, you got idiopathic Parkinson's disease. Come back and see me in 6 months, and we'll see how you're doing, see if we need to adjust medications, those kind of things. But go see some physical therapy, get your exercise program going, that kind of stuff. You start seeing the patient. You're seeing them maybe, let's say you see them for 4 to 6 weeks, and you're doing kind of, you see them 3 times a week for the first week, and then you're kind of, reducing the amount because you're teaching them their home program, getting involved in a community-based exercise program. But all of a sudden you notice that their symptoms are getting rapidly worse. And you check their blood pressure, and you notice that from sitting to standing, their blood pressure is just bottoming out. And you notice that they seem to have a little more like cognitive fog or dementia than you would expect. and maybe their heart rate doesn't respond to exercise as you would expect when you get them on. There's no cardiac acceleration when you do that. And their gait is getting much worse more quickly than you thought. That's somebody that probably has more of a multi-systems atrophy. I've caught this on probably 10 occasions where a patient comes to me with idiopathic Parkinson's disease. They start having a more rapid progression with autonomic problems and other things, or they can't move their eyes as well, the progressive supranuclear palsy. If you're going to catch that early, get them back to the doctor, okay, and say, I'm not sure this is idiopathic. Can you reevaluate them? Because you're seeing them constantly. You're knowing how they're responding or not responding to treatment. The other way they diagnose the multi-systems atrophy is normally you wait to give somebody the dopamine, like Sinemet, because it only has a therapeutic window of whatever, 5 to 10 years before you don't get any benefit from it anymore. They want to delay when they give that to you to an extent. And so normally they won't start you on that. But if you start seeing this rapid regression, what they'll do is they'll give you some doses of Sinemet. If you respond to the Sinemet well, then you probably have idiopathic Parkinson's disease. If you don't respond to the Sinemet, you probably have a multi-systems atrophy, because multi-systems atrophies don't respond to Sinemet, not nearly as well. They respond a little bit, but usually Sinemet with idiopathic was like, wow, it's like, whoa, I'm normal again, when you first start taking it. But with multi-systems atrophy, it doesn't change their event very well. Okay. So here's the direct and indirect pathways separated. Here's Parkinson's disease, okay? The other thing now we're going to add to the mix is here's acetylcholine. These are interneurons in the striatum. And remember, acetylcholine has the opposite effects of dopamine. So acetylcholine is inhibitory to the direct loop and excitatory to the indirect loop. I'm just pointing it out because it's in the picture. We're not worried about it with Parkinson's disease. We will be worried about it when we get to Huntington's disease, okay? So for right now, you can ignore that. But just understand that there's some acetylcholine interneurons in the striatum that also influence the direct and indirect pathways. But right now, they balance each other out. Don't worry about them, okay? So right now, all we're worried about is dopamine. We're worried about the substantia nigra. Parkinson's disease, you lose. So that's what they're showing here is the death of these dopaminergic neurons are lost. So you lose this excitatory influence of the dopamine falling on the D1 receptors over the direct loop, and you lose the inhibitory influence of the dopamine over the indirect loop. So the net effect is the direct loop is no longer working as well or as strongly, and the indirect loop is no longer inhibited as much, so it's working better. So the net effect is less motor output because the direct loop normally excites motor output, but it's not doing its job as well. The indirect loop is normally inhibited because the indirect loop lowers motor output, but now it's no longer being inhibited, so the indirect loop is inhibiting motor output. So the net effect is a decrease in overall motor output. Direct loop got turned down, the indirect loop got turned up. You lost that balance between the two, okay? That's Parkinson's, okay? Now we're getting into hyperkinetic disorders. Huntington's disease, hereditary degeneration of the striatum and the cerebral cortex. Huntington's disease is very specific to the striatum, the caudate and the putamen, and specifically to the cholinergic neurons, those acetylcholine cells in the striatum and putamen. But it also causes cerebral cortex, especially frontal lobe and temporal lobe. These people have behavioral cognitive problems. So Huntington's disease, they have these excessive motor output, but they have profound cognitive dementia eventually as well, because it not only kills basal ganglia cells, but it kills cortex cells. The choreic movement is that dance-like movement. We already talked about athetosis, hemiballismus, and I already mentioned dystonia. So those we've seen the videos of those. So those are some of the common movement disorders associated with hyperkinetic disorders of various types, including Huntington's disease. Huntington's tends to have the chorea and the athetosis, or some combination of those two. So, Huntington's disease is a loss of acetylcholine cells. Parkinson's is loss of dopaminergic cells, okay? And so when you lose dopaminergic cells, the influence those dopaminergic cells have over the direct and indirect loops is that when you lose them, you have too little motor output. Remember, acetylcholine cells have the direct opposite influence over the direct and indirect loops as the dopamine. So when you lose acetylcholine cells, you have the opposite effect of loss of dopamine. You have too much movement now. Now what happens is normally the acetylcholine helps to balance and helps to inhibit the direct loop and excite the indirect loop, or excite the indirect loop. So now you have too little inhibition over. So you lose the inhibitory influence of the acetylcholine cells over the direct loop, and you lose the excitatory or increased activity of the indirect loop. So the net effect is too much motor output. So they're excessive or hyperkinetic disorder. So acetylcholine helps balance against the dopamine. So it's always this balance. It's this fine, delicate balance between excitation and inhibition. So all you need to know, Huntington's disease affects acetylcholine cells in the striatum, which destroys the balance between direct and indirect loops, and now you have too much movement, okay? Where Parkinson's affects the dopamine in the circuitry, which its net effect is too little movement because of its influence of the direct and indirect loops. This is somebody, so this is a normal brain right here in the top. And then you can see the normal brain has this nice big putamen, nice big caudate, striatum, right? The one below is Huntington's disease. Putamen is actually pretty small here. Most of this is globus pallidus here and here, but this is the putamen out here, very small. This one's much more plump. And then even the caudate is smaller here. It's kind of smaller and narrower. It's atrophied. So that's the loss of the striatal cells, those acetylcholine producing cells in the striatum in Huntington's disease. But you also see just the general atrophy of the cerebrum. You see how big those folds are, sulci, and how atrophied the cerebral hemispheres look. So that's where the general cognitive deficits and so forth come from. Don't worry about hemiballismus. Just know hemiballismus affects the subthalamic nucleus, which is part of the indirect loop. So it makes the indirect loop not work, and so now you have the direct loop doing more work, having more influence than the direct loop. So more than the indirect loop. So you're damaging the indirect loop. So now the direct loop, which is excitatory, has more of an influence, relatively speaking. And so you have too much motor output. That's that wild flinging of the arm and leg on one side, okay? Good old cerebellum. We're going to stop here. I don't think we want to do any more damage today than I've already done. So, just trying to think if I can make this summarize very simply. Basal ganglia helps to initiate movement, switch from one program to another. You've got two competing pathways through there, two loops that balance each other out. One increases movement, one decreases movement. Dopamine helps to, when you squirt more dopamine, it makes the direct loop more active, which increases motor output and inhibits the indirect loop, okay? So when you take dopamine out of there, it lowers the amount of movement output for Parkinson's disease. We also have some of these acetylcholine cells that are also in the striatum that have the opposite effect of dopamine. They balance out the dopamine, and Huntington's disease damages those acetylcholine cells. So since they have the opposite effect, the direct loop is now overactive and the indirect loop is underactive. So now you get too much movement, okay? And you got something like a hemiballismus that affects the indirect loop, damages the indirect loop, and now the direct loop is not being opposed properly, so there's too much movement, okay? I think that kind of summarizes how that works. You know, You don't have to know, you do have to know, like, there's neurotransmitters. There's excitatory and inhibitory neurotransmitters and what they do. You should know dopamine and acetylcholine, their influence over those, general influence, but you don't have to know the individual connections at each point all the way along the way. Does that make sense? But I think it's good to have appreciation for those connections, for, again, for your knowledge, for your reading, and those kind of things. Your book doesn't go into any of that, does it? Into the well, do they go into some of that? No, they do go into some of that. Sorry, I'm thinking cerebellum. Cerebellum, we get to cerebellum, they don't go into some of the detail that I think is a little bit needed for a good understanding of that. So, cerebellum will be a little shorter, a little less, but it's still a little bit of a challenge, but you'll get through it. Everybody else has in the past, so.